I just find it fascinating when, like for example, in stem cell regeneration, how you have, like for example, a pluripotent stem cell that uh, like for example, like an embryonic pluripotent stem cell, or a like if it's in the lab in a petri dish or something, how it can differentiate into a tissue, and then how those tissues can grow into a eventually a complex structure like an organ. It's just fascinating to me, like all the, I guess, the transcription factors that have to be activated, like, and then it's just interesting to see this cell is going to differentiate into this tissue type versus that tissue type, you know? Um, is there any way that you control that outside, like in the lab? Or do you select, for example, if you want to grow a uh, liver specific tissue, do you take like a biopsy of that liver sample and then try to focus on growing that? Or do you just start from a basic undifferentiated stem cell and then go try to differentiate it?
So, I mentioned at the beginning of the show that the answer in science is always, it depends. And the answer to that question is, it depends. And that's not a satisfying answer, I know, but, it really depends on how proliferative a particular tissue type might be, right? So my work focuses on skeletal muscle regeneration. So I can talk a little more specifically on that, but I think the principles really apply to every tissue type here. Something like a neuron, if you go and try to culture neurons in a dish, not only are they notoriously hard, but when you have that mature neuron, it's going to be super difficult to get that to proliferate. As opposed to something like the skeletal muscle system, where I can actually go in and take a biopsy of, let's talk about human cells for a minute. If I take a human biopsy, I can find the muscle-specific progenitor cell called the satellite cell within that biopsy. Or I'm likely to anyways.
Mm-hmm.
And I'm able to keep that in culture and actually just use some very simple techniques in order to get those cells to expand because they naturally want to proliferate. Certainly, you addressed a really interesting point here in that not all cells want to. So certainly some cells we need to administer maybe some transcription factors to get those to proliferate. Sometimes, right, we want to roll those cells back into a more proliferative, induced pluripotent state in order to get those to start to proliferate and then differentiate. So we have enough cells to stick together to make our particular construct that we're looking at. At least I get pretty lucky in that I chose to work with Dr. Tracy Criswell and Dr. Shai Soker, with Dr. Tracy Criswell being my primary mentor. In doing some of the skeletal muscle regeneration work. And I didn't know it at the time when I joined her lab, but skeletal muscle happens to be a little easier on that particular topic, right? Because I can grow and culture these satellite cells. And although the primary satellite cell, that primary stem cell, it's a little finicky. I came in mostly with animal experience, and while I was here, I learned that cell culture technique and was really surprised at how tricky and temperamental some of those cells could be to grow. But overall, they like to grow. They like to proliferate. In order to get them to differentiate, I then, and this is very standard for the field, right, I just have to change my growth media. I switch from a high serum content to a low serum content. And I let those cells get really packed in with a lot of neighbors, right? Really, the signaling cues for them are low serum. And when I'm touching a lot of neighbors, then those cells start to fuse and become myotubes and differentiate into these nice, long, mature muscle cells. So I got really lucky that the answer to your question there for muscle is, well, you just let them grow, as opposed to other tissue types, which is, I might really have to administer some transcription factors, whether it be to turn on a transcription factor with either a drug or a particular cytokine, for example, or something else. Part of my work also focuses on the role of macrophages in skeletal muscle healing and wound healing. And so at least with those cells, when I'm culturing macrophages and want to differentiate to a particular subtype, that's when then I have to stop and go, what cytokine do I need to administer to get that cell to differentiate?
So if I guess get this straight. So skeletal muscle cell regeneration, it happens when there's, for example, like satellite stem cells, and then if there's like an injury, there's an inflammation reaction, and then the macrophages come in, they activate the satellite stem cells, and then the satellite stem cells, they activate myoblast differentiation, which goes into which grows the myotubules, and then it becomes mature functional myofibers. Is that kind of
Yeah,
the right idea?
yeah, that's the right track right there. The hardship for this, right, is that especially in humans, animals do a little bit better job of regenerating. But one of the important roles of macrophages, right, is to cause a lot of that inflammation. And then you've got some fibroblasts in the area of an injury, where as the macrophages are degrading those damaged and dying myofibers, your fibroblasts are laying down collagen, right? They're laying down scar tissue. And so really think of it as kind of, you got a road and they're patching these potholes, but they're not patching it with, good cement. They're patching it instead with a big bit of tar. And so humans, unfortunately, we don't do a lot of that tissue remodeling. And so if we think about muscle regeneration, right, well, what are some strategies to attack this problem? Do we reduce the amount of inflammation? That's a potential strategy. Do we reduce the amount of scar tissue formation? That's a strategy. Can we get those muscle satellite cells to proliferate more, start to differentiate into myoblasts, and then start fusing into myotubes at a faster rate than the other cells? Also a strategy, as well as any combination thereof. There's been some elegant papers out over the years that have looked at eliminating one particular pathway, and unfortunately, it's a much harder problem than just blocking or activating one particular thing. It's really this complex interplay and puzzle of all three. And certainly that's why I'm in the field, right, of science, is I like these puzzles. I like these challenges of, it's not just an on-off switch all the time. It's not just one easy answer. It's a little bit of pot A, it's a little bit of pot B, it's a lot of C. How do you get these to work together?
And then another question I have is, like, once you grow the muscle fibers, you also need to revascularize the microtubules, as well as have proper innervations to those muscle fibers. Do you also work in that aspect as well? Because growing it is one thing, but having the proper innervation as well as the proper blood supply is a major component to having it function.
Absolutely, man. Raghu, you just hit the nail on the head for like the most complicated problem of regenerative medicine right there. So I get really lucky in my work in that I'm working on a particular drug to see how it can stimulate this process in vivo, rather than trying to grow my entire tissue outside of the body and implant muscle. And certainly, WFIRM, the Wake Forest Institute of Regenerative Medicine, certainly we are trying that as well. But that vascularization challenge and that nerve axonal growth challenge is super difficult. For at least my work in skeletal muscle physiology, we're kind of hijacking the body, right? We're looking at a particular type of injury, compartment syndrome, but we're relying on the body to have those particular cues, right? So for that vascularization to happen naturally, for that axonal projection to happen naturally as the cells reproliferate and take over the damaged areas. And I think maybe skeletal muscle is a little bit easier of a tissue type in the long term, that we'll maybe see some treatments come out of, because it likes to do that, right? Our muscles heal pretty well after a lot of injuries, right? Something like a sports injury, right? Compared to other tissue types. So we're a little lucky in that. For growing tissues outside of the body, I think one of the most popular strategies is to throw in, I think it's, we throw in some different endothelial cells to say, hey, here's some of the different cell types we're going to need to get this to vascularize. That right there, right now, is across the world, to the best of my knowledge, the biggest challenge in regenerative medicine. How do you make these larger structures, right? You need blood supply, and it is so difficult to get that vascularization, particularly that capillary network, those tiniest of blood vessels throughout your tissue construct. And I think that's really the biggest hang-up at the moment across the world for being able to, whether it be 3D print, to grow in a petri dish, take your pick, getting these larger tissues that we can just say, hey, we'll take a biopsy, come back and see us in 3 months, 6 months, what have you, and we'll have your new liver ready, or we'll have your new kidney ready, or whatever it might be. We're having a hard time with that. And certainly the issue of innervation is really difficult. I know with some of the tissues that we have implanted and we've got ongoing clinical trials for, we've gotten really lucky that we said, well, we're going to put the tissue type in here and we're going to hope that the body naturally reinnervates, at least for several tissues that we've tried. That has happened. In particular, Dr. Atala's bladder project, for which he gained quite a bit of fame and notoriety, and was able to start W4. Right? He grew a new bladder for some pediatric patients ex vivo using biopsies, and then reimplanted them, saying, hey, at least now you've got a new bladder, and that naturally reinnervated, to the best of my knowledge.
Have you, what was I going to say? So with your studies, have you mainly focused on, for example, the muscle injury? Has it been mainly compartment syndrome or a crush injury? Because I think I was reading your paper, and you mimic this in the experimental lab animals by putting a blood pressure cuff and pumping the blood pressure cuff as tight as it'll go to mimic compartment syndrome. And once there's muscle injury, then you go in and try to focus on implanting or stem cells and look at how many days from that injury period it takes to grow the muscle, revascularize, innervate, and you test different components in that.
So this is a really tricky question for overall the field of physiology, right? How do we accurately mimic a human injury, right? How do we study this? And so one of the things our lab has published multiple papers on, Dr. Criswell has published multiple papers on, is this compartment syndrome injury? And so she's looked at exactly that, right? What different pressures do we need in order to induce compartment syndrome? This particular type of skeletal muscle injury, it's more of a ischemic reperfusion injury followed by a non-localized edema, right? So there is swelling of an entire muscle compartment without a localized amount of fluid buildup that a physician can just drain. And so in order to mimic this, right, Dr. Criswell said, well, okay, I think we can get this by maybe wrapping a blood pressure cuff around a hind limb. Well, how much do we inflate that to? So we don't quite go to the max there, right? We go to 120 to 140 millimeters of mercury. And again, Dr. Criswell has this well published, so if anybody wants to look it up, they're more than welcome to. And so, hey, we're able to induce this injury by inflating a blood pressure cuff around a muscle grouping to a high enough pressure to occlude blood flow, but not to cause a crush injury, right? We don't want to have that be the primary way of damaging those myofibers. And so we've looked at a number of different pressures. That's how we came up with that 120 to 140 number. And then we also looked at, well, how long do you need to occlude blood flow before you start seeing this overall non-localized swelling in that muscle compartment? And so we came up with 3 hours. We said, okay, this is great. If you keep a blood pressure cuff inflated for that long, just enough to occlude blood flow, well, then when you release it, you have all of that blood rushing back to the injured compartment now, really causing this massive swelling. We've tested all kinds of different time and pressure components, and that was kind of the sweet spot that we've published on and that we proceed with in our injury model.
And do you know what for example, I guess from my understanding, the treatment for a compartment syndrome is a simple, I mean, I say simple, but fasciotomy. But I'm always curious, is there, for example, is there anything else that is being done besides just a fasciotomy to release the pressure to regrow the cells? I know that's what you focus on, but for example, in clinical practice, are they giving like a stem cell dose to the compartment syndrome to help regrow those cells, or is that all in testing phase?
Yeah, so I think this is just you touched on regular the sweet spot of where we are at right now. So we got a big grant from the military actually to study compartment syndrome, and so that's kind of what led to the beginning of our work at the institute. And so that's the really fascinating and hard puzzle to me. And disclaimer, I'm not a clinician. I've been very lucky to work with several clinicians on this project. But it seems that that's what's done in the clinic, right? Is, okay, you've got this swollen muscle compartment in a human. If you do nothing, that person is likely to die at worst, or at best, you'll have to amputate the entire limb.
Mm-hmm.
And those are not good outcomes. So they said, all right, well, we've got this pressure accumulation. How do we treat this? And so what the physicians will do is they'll do the fasciotomy surgery, which is to go into that muscle compartment, cut that fascia, that connective tissue between your muscle groups, and leave that site open. So now you've got these swollen muscles that now have an area to expand into, right? Before they were bound by your skin and they're butting up against that. So now they've cut open your skin, you have these deep incisions, you've really cut away a lot of that connective tissue, and you have these large swollen muscles. But because the swelling is not localized to a particular pocket of fluid that they can drain, the standard of care is to keep that fasciotomy surgery site open and clean in the clinic until pressure naturally resolves. Some patients get lucky and it's only a few days, which to me, lucky in a few days still does not sound great. I think, so the average time to closure is about 7 days on that. But it can take a couple of weeks for some patients, and that's not good. And what you're left with once that pressure resolves and that site is sewn back up is a lot of long-lasting damage, right? You've got a lot of scar tissue deposition. Mm-hmm. Now, while that surgery site is left open in the clinic, that area is being cleaned. As your body tries to lay scar tissue down to patch that surgical site that's just been created, the physicians might have to come in and debride the area. But this is where I think the field of regenerative medicine has some really great potential, which is to say, well, right now there's not good treatment other than managing the symptoms, managing the pain, and saying, well, there's not a lot we can do here for muscle growth. Mm-hmm. And so that leads to our lab and what we are doing, right? Can we potentially do stem cell injections, right? While we've got that site open, could you take a biopsy, grow some stem cells, and give those back to the patient? Right, so now you're getting around this area of immune rejection because we've worked with the patient's own cells. Could you give a drug at some point in time that will stimulate those native satellite cells, those muscle stem cells, to start to grow and repair that injury? How can we really restore function? And to me, that's kind of the heart of what we're doing with physiology, restoring full function. Mm-hmm. And I think, like I said, I think this is the sweet spot of regenerative medicine, because there are no other good outcomes for this, right? You have to stimulate those cells to grow. And that's certainly what we're trying to do.